Rhodococcus infections are uncommon, however, they can cause serious disease in certain patients. There are a number of challenges, though, when dealing with Rhodococcus infections, including the fact that much of what we know around their susceptibility profiles and the clinical management of infected individuals actually comes from a number of case series and, in some situations, from the veterinary literature. So today, our two guests are going to tell us about their experiences with Rhodococcus over a 10-year period and bring us up to speed on things like which species of Rhodococcus are most commonly isolated and associated with clinical disease, what is the recommended approach to susceptibility testing for Rhodococcus, and what sorts of susceptibility trends do we see at both the genus and species levels? And also, of course, we're going to talk about the clinical manifestations and outcomes of clinically significant Rhodococcus infections. Welcome to Editors in Conversation. I'm your co-host, Ellie Thiel, and am here with JCM Editor-in-Chief, Dr. Alex McAdam from Boston Children's Hospital. Alex, how are you on this fine April day?
I am doing very well, but it's not fine here. It's very rainy and cold.
Oh, we
Looking
win.
forward to a good weekend, though.
It's sunny. I think it's sunny. I don't have windows, but I believe it's sunny outside.
It is
Of course you
sunny.
don't have windows. We're in lab medicine.
Yeah. So we have some exciting news to share. Last time we
Yes.
teased that we will be making a surprise appearance at a session at Microbe, but we have more news this
Yeah.
time. Do you want to share?
Well, should we say what session we're going to make our appearance in?
Yeah, I suppose.
All right. Go
You
ahead.
go. Oh,
Well, I hope I have the name right, but it's the Battle of the Brains session.
it is. So we will be
We're not answering questions.
We're not answering. No, we're not answering questions. We may be posing questions.
Yes.
So that should be fun.
So we'll be doing
But
a little
then,
drop-in.
yeah. And we also are going to be recording our live JCM Editors in Conversation podcast at Microbe. It will be on Saturday, June 15th at 11 a.m. Our guests are still a mystery, so it'll be a surprise, but we hope you guys can join us there. And I'm sure we'll have fun as always.
We have a very good idea of what sorts of people we are inviting, but they have not been finally chosen yet.
That's right.
So, but it will be fun. It will be very clinical, and it will probably be very closely related to case reports.
So hint, hint.
Pretty heavy-handed there. If you keep track of what ASM Journals is getting up to.
That's right. So we hope that you've all enjoyed previous editions of Editors in Conversation, and we ask that you please subscribe and rate or review them wherever you get your podcasts. We appreciate both positive and constructive feedback. This episode is brought to you by the Journal of Clinical Microbiology, available at jcm.asm.org. And the podcast is supported by the American Society for Microbiology, which publishes JCM. And just to remind all of our listeners that if you're considering publishing in JCM as an ASM member, you will receive up to 50% off of publication fees, which is a nice perk. So today we are joined by two first-time guests, including Dr. Nancy Wengenack. Dr. Wengenack is a professor in the Department of Laboratory Medicine and Pathology here at Mayo Clinic in Rochester, Minnesota, where she directs the mycology and mycobacteriology laboratories. Welcome, Nancy, and thanks for joining us.
Thanks, Ellie. Appreciate the invitation.
And then we are also joined by Dr. Adi Shah. Dr. Shah is an assistant professor of medicine and a consultant in the Division of Infectious Diseases, also at Mayo Clinic in Rochester. And his interests include critical care infectious diseases, antimicrobial and diagnostic stewardship, emerging infections, and emergency preparedness and planning. So he has a lot on his plate. So it's great to have you on today, Adi.
Thank you so much. Excited to chat and learn together today.
Yeah, great. So the two of you, along with a number of co-authors, recently published a manuscript in the February issue of JCM entitled Rhodococcus Infection, a 10-year retrospective analysis of clinical experience and antimicrobial susceptibility profiles, which grabbed my attention. And actually, I have to ask, Alex, on a scale of 1 to 10,
Yes.
how shocked or impressed were you that I selected a paper with any sort of AST in it?
11.
Oh, 11. Yeah, I thought that would be a surprise.
But I was very
But
pleased. You know, I
yes,
love my AST.
I think it might be growing on me, but we'll see how we do today. So, I guess regardless of my love for all AST topics, we're going to get right into it and kind of talk about what you guys found in your study. And Nancy, we'll start with you. Can you refresh us on Rhodococcus as an infectious agent and talk about what type of pathogen it is, what species are classically associated with infections, and how does transmission typically occur?
All right. Well, thanks, Ellie. I'm happy to talk about that. So, Rhodococcus is a genus within the aerobic actinomycete group of bacteria. And sometimes when I say that, I instantly confuse my students when I talk about aerobic actinomycetes, which is never good because they become confused and think about the actinomyces species, which are anaerobic bacteria. But the aerobic actinomycetes are a group of aerobic gram-positive bacilli that form rods and sometimes can exhibit simple branching growth. They have a high GC content because many of them contain mycelic acids in their cell wall. And probably the most recognized genus within the aerobic actinomycetes are the Mycobacterium. And they're often considered and discussed separately because of the clinical significance of some of the species like Mycobacterium tuberculosis and Mycobacterium abscessus. But I like to think of the other aerobic actinomycete genre as first cousins of the Mycobacteria. So there are approximately 20 different genera, and probably the most medically important one are the Nocardia species. But also don't forget Gordonia species are part of this group, not to be confused with Mycobacterium gordoni, the tapwater bacillus. So again, similar names cause a lot of confusion for students and
Mm.
sometimes physicians as well. But other important genera, Streptomyces species, Suchomerella species, and then of course today we're going to talk about the Rhodococcus species, which is important as well. So within the genus Rhodococcus, there are about 57 recognized species, and there's probably more that haven't been described yet. Rhodococcus equi is the most frequent species that we see causing disease in humans. It's ubiquitous in the soil. It likes to grow in soil and in manure and in the large intestine of herbivores. So it's a significant veterinary pathogen, particularly of horses, and especially really young foals have a high morbidity and mortality due to Rhodococcus equi. But it's also an important human pathogen, as we can see from the data in our paper as well. Mainly affects the immunocompromised host, as Dr. Shar will talk about more in a few minutes, causing lung infections. But as you can see from some of the data in the paper, we see it in other places in the body as well. So transmission is thought to occur via inhalation of airborne dust containing Rhodococcus bacilli, but accidental inoculation is another possible route of infection.
Mm. Yeah, it's a very well done study. I think it's interesting that you bring up the confusion around the different names. And kind of to that point, are there any taxonomic changes that we should be aware of with these particular agents or that you'd want to point out in particular?
Yeah, as a mycologist and a mycobacteriologist, my world is filled with taxonomy controversies. So, and Rhodococcus is no exception. So, but it's pretty confusing. Rhodococcus was first described in 1923, and it was given the name Corynebacterium equi, and it has kept that name for a long time until 1977, which is fairly recent history in my mind, but is getting to be quite a few years ago now. And in 1977, it was renamed Rhodococcus equi, and that's the name that most laboratories and most physicians are familiar with today. Then in 2013, there was a proposal in the literature to, based on some phylogenomic studies, to rename it Prescotella equi, and that proposal has met with some controversy and back and forth discussions in the literature. There was some support for a short time to change the species name from Rhodococcus equi to Rhodococcus hogei, and that name made it into the literature and some instrument manufacturer databases. So you'll sometimes see reports of Rhodococcus hogei. Ultimately, that name was rejected by the Judicial Commission on the International Committee of Systematics of Prokaryotes. But as you can see, the taxonomy is clear as mud, right? So my take home for listeners is that if you hear the names Rhodococcus equi, Rhodococcus hogei, or Prescatella equi, they're essentially synonymous. And we elected in our manuscript to use the name Rhodococcus equi as that's the one that's most widely recognized by physicians who will be treating patients that are infected with this organism.
Thank you, Nancy. Adi, let's get a little bit of clinical perspective. Can you tell us what patient groups are at highest risk for infection by Rhodococcus species? What would the manifestations be, and what the typical approach to treatment is?
Sure. So as Dr. Venjanek said, great credit goes to Dr. Nichal Ranganath, who did some great amount of heavy lifting, and most importantly to our lab colleagues. So Dr. Venjanek mentioned the takeaway of the names, but my takeaway would be keep close relationships with the microbiology lab and work with them closely, because one of these patients was misdiagnosed, or at least initially thought to have pulmonary tuberculosis, because the gram-positive rod nature of this pathogen was initially misdiagnosed as mycobacterial TB in one of the patients. And then we got more information from the microbiology lab because it didn't really make sense. And that's how we were able to narrow down that it's actually Rhodococcus equi infection that the patient had. But coming back to your question and adding to what Dr. Benjanek said, is that it's usually acquired by inhalation or local inoculation, and usually causes most predominantly pulmonary disease, but can also cause extrapulmonary disease, including bacteremia. It can also cause device-related infections with devices or invasive catheters like central lines, dialysis catheters, VP shunts, and so on. The classic host or the patient who can get clinically significant infection from any sort of Rhodococcus species is usually immunocompromised, solid organ transplant, bone marrow transplant, or HIV patients, very rarely, if at all, seen in the immunocompetent host. And most commonly, the infection source is cavitary upper lobe pneumonia, or a cavitary sort of a pneumonia in the lung from which it can then get into the blood. And it can be misdiagnosed as pulmonary tuberculosis. So it's very important to know that piece because of its morphological similarities to mycobacterial species. Extrapulmonary manifestations can happen rarely, and they include brain abscesses, subcutaneous skin soft tissue abscesses, meningitis, or encephalitis type symptoms if they have devices such as VP shunt, and also catheter related infection.
Thanks, Addie. I think your point about confusing this with Mycobacterium tuberculosis is a really important one. So I guess I'm always interested to know how people come up with the studies and their projects that they pursue. So was there a certain case, or what really prompted you and your team to kind of undertake this study and focus on Rhodococcus?
Sure. So as you mentioned initially, my interest also includes emerging infections or newer pathogens. And with the rapid evolution of diagnostics such as MALDI-TOF, we are seeing more and more names of organisms that the microlab results, and all of us are like, I've never heard of that before. So we have thankfully great relationships with our microbiology lab, bacteriology, mycology, and all parts of the microbiology lab. So every time we see a newer name that all of us are like, we've never heard of this before, I have contacts with my group of mentees with lab scientists and lab techs, who we reach out to and say that, hey, we are seeing this organism. Have we seen it before? Can you pull some data, de-identified, of course, over the last X number of years to see how many times we've seen this pathogen before? What are the age groups that we've seen it before? What is the temporality with year by year identification? What source have we seen it before? And if we see that we've seen a lot or a decent amount of it before, and we don't know what to do about it at present, we then write an IRB, go deeper into pulling more granular data, like the patient population that it is isolated in, the clinical comorbidities that the patient may have, their Charlson comorbidity index that they may have, the type of host that they might be. And then we get deeper into the sources of infection that they may come from. Because my hope with our group of mentees is that if somebody has this type of a reaction, I've never heard of it before, they go on PubMed or Google. And we hope that our paper would be a paper that would guide future clinicians on what to do with these pathogens of we've never heard it before. And I've done more than a few papers that we've submitted to your journal so that we can guide future clinicians on what to do with these. I wouldn't say novel pathogens, but certainly pathogens that we are seeing more now. I don't think they're novel. It's just that we are getting better at identifying them,
Mhm.
thankfully, to advanced technology that colleagues like you guys in the microbiology space help us identify. So that is usually my game plan with my mentees is, okay, we are seeing something new, talk to your micro lab, pull some data, write a quick IRB, look at granular data, look at
Mhm.
susceptibility differences, so that in the future, if we see this, then we know what should be your empiric regimen, when do you suspect it, when do you take it seriously, not what diagnostic tests, et cetera, et cetera.
Nice.
Thank you, Eddie. And you started to get into this, but can you fill it out for us? What was the structure of this study? What was the approach you took in the study?
Sure. So this is a 10-year retrospective review. We at Mayo Clinic are a reference lab, so we get samples sent from all over our Mayo Clinic clients. So the structure of the study was to first just look at the total number of isolates of Rhodococcus species, both equi and non-equi species that we have received at our lab, and look at the susceptibility patterns in both those. And we also wanted to do some clinical review of actual patients that were seen at our center so that we could see if we could learn anything different from an actual clinical experience. So it was a two-pronged study to look at general susceptibility patterns of equi and non-equi species over the last 10 years, and also to look at clinically significant cases that we have seen here over the last 10 years to describe the kind of host that gets it, what were our empiric strategies, what was the median age of that patient population, what was the duration of therapy, sources of infection, and so on. So that in the future, if some clinician outside of Mayo or in Mayo were to see an isolation of this pathogen, they would be able to make out what should be the empiric regimen, what would be the classic patient that they should suspect that
Mhm.
infection in. So that's our usual game plan for all these types of isolated pathogens.
And, Adi, just to make sure we've got it right, the susceptibility data and perhaps some of
Yes,
the species distribution, that's from Mayo patients as well as specimens
yes,
received from outside.
that's
But the
right.
clinical analysis was based on patients seen at Mayo Clinic. Is that
That's
right?
right.
Gotcha.
Yes, exactly
Thank you.
right.
Very nice. So, Nancy, kind of getting
Mhm.
into it, can you summarize for us what methods are we currently using in the lab to detect and isolate Rhodococcus from samples?
Sure, I can do that. So, Rhodococcus is pretty readily detected in standard mycobacterial cultures. They grow well in Middlebrook broth that's used for mycobacterial culture or on agar plates containing Middlebrook medium or Lowenstein Jensen medium that are used for our mycobacterial cultures. In our study, we had 32 isolates recovered from our Mayo Clinic patients, and they grew in an average of 10 days in Middlebrook broth medium, with the range being 2 days to 29 days. And as we also see with mycobacteria, rhodococcus isolates tend to grow a little bit more slowly on the agar medium than in the broth medium. And so they had an average time to positivity of 19 days on the solid agar medium, in a range of 3 to 40 days. So since mycobacterial cultures are held for up to 6 weeks at most institutions, mycobacteria media is where you're going to most likely recover the aerobic actinomycetes like rhodococcus species, but sometimes you'll recover them on standard bacterial media or even fungal media. But oftentimes the bacterial or the fungal cultures aren't held quite long enough to recover rhodococcus. So that's why you see them most often on mycobacterial media, since they average 10 to 19 days for growth. And then once a positive culture is detected, we'll perform an acid fast stain to look for mycobacteria, and then a modified acid fast stain to look for the aerobic actinomycetes, since many of the aerobic actinomycetes are modified acid fast positive. But Rhodococcus is a genus that is only weakly modified acid fast positive, so the modified acid fast stain has to be interpreted with caution, because just because it's negative doesn't mean it's not a Rhodococcus species. So, but once we have culture growth, it's fairly easy to identify Rhodococcus species using either multi-TOF mass spectrometry or Sanger dideoxy DNA sequencing. Of course, you could use next generation sequencing as well, but it's usually not necessary to go quite that far, as some of the standard methods are pretty good at identifying it. The 16S ribosomal RNA sequencing target is a good one for sequence-based identification of aerobic actinomycetes, and it allows identification to the species level for many Rhodococcus isolates. But as we saw in our paper, a fair number of them were identified only to the genus level because their sequence didn't match any Rhodococcus species in the available sequencing databases, including NCBI's GenBank. So it's likely that there are more species out there to be identified. So that's future work to be done, I think, in the Rhodococcus world. So
Thank you. And look at this. Ellie gave me the question about AST.
Of course.
Nancy, how do you approach susceptibility testing in Rhodococcus? How do you do it, and
sure.
how do you decide which isolates to do it on?
Sure. Well, we use the Clinical and Laboratory Standards Institute, or CLSI, reference method for testing of aerobic actinomycetes. So that's the broth microdilution method. And that method is outlined in CLSI document M24, which is entitled Susceptibility Testing of Mycobacteria, Nocardia species, and Other Aerobic Actinomycetes. So that's where Rhodococcus testing would fall into that document. The third edition was published in 2018. We're actually discussing revising that now, so there'll probably be a new edition in the somewhat near future. The antibacterial agents that should be tested or that are recommended to be tested, and the breakpoints that we have and interpretive criteria can be found in another CLSI document. So that's M24S, which is the performance standards for susceptibility testing of those organisms document. And that one, the second edition, was just published last year in 2023. So that's the current version of that document. So we perform susceptibility testing on all significant sources like blood and CSF at the request of our infectious diseases practice committee. Testing of sources where the Rhodococcus may be an incidental finding or commensal, maybe like from sputum or on isolates sent from our reference laboratory clients, actually requires a physician's order, and then we can do the testing. So
Nice. So you kind of touched on this earlier, but can you kind of get into it a little bit more and talk to us about, the Rhodococcus isolates that the lab recovered over the last 10 years? So, what were the most common species? Although I think we can probably guess that one. But did you also see any interesting trends in Rhodococcus recovery over that 10-year time frame?
Sure. So in our 10-year study, we saw 322 Rhodococcus isolates, or an average of 32 per year. In figure 1 of the paper, we looked at the distribution over time, and we found it was pretty steady at 20 to 30 isolates per year from 2012 through 2019. And in the last 3 years of the study, we saw kind of a rise in the number of isolates, and it peaked at 53 isolates in 2021. Now, I don't know if that's a true trend or not, because we know during COVID, we had a lot of hospitals that would outsource a lot of their mycobacterial and their aerobic actinomycete testing because they were just very busy trying to do COVID testing. So it could be an artifact of a COVID, pandemic artifact, rather than a true increase in the number of isolates. But, somewhere between 20 and 30 isolates a year is probably pretty typical for us. About 50% of the Rhodococcus isolates that we saw in our study were recovered from blood, about a quarter of them from pulmonary sources, and then bone and joints were the third most common sources at about 12% of the total isolates. So if we look at the breakdown, Ellie, as you kind of guessed, Rhodococcus equi is the most common species we recovered, and it accounted for about half the isolates. After Rhodococcus equi, the most common species are Rhodococcus carinibacterioides, Rhodococcus erythropolis, and then my favorite microorganism name, Rhodococcus rhodococcus. So that's a tongue twister right there. But that was third most frequent, so in terms of non-equi species. And then, as we mentioned earlier, about 19% of all isolates weren't able to be identified to the species level, suggesting either a mutation under the 16S sequencing target or that there's more species out there that are yet to be described. So
Adi, let's turn to the isolates from the patients at Mayo Clinic, where you had the clinical information. What can you tell us about those clinically significant infections with Rhodococcus?
Sure. So at Mayo Clinic, we had identified 32 patients with isolation of these organisms, out of which we evaluated that 10 were true infections as defined as the treating clinician or the infectious disease clinician thinking it's a true isolate and getting treatment, and 22 were deemed to be non-clinically significant and counted as either a contaminant or a colonizer. For the 10 that were thought to be true infection, Rhodococcus equi was the causative pathogen in 7 patients, with the majority of patients presenting with a primary pulmonary process like a pneumonia with a consolidation or a cavitary pneumonia or nodular disease or an empyema. And 2 patients developed concurrent bacteremia along with their primary pulmonary process, and 1 case of isolated central line associated bloodstream infection. 2 of these patients developed empyema, which required thoracotomy and decortication for source control, so pretty significant infection. And out of the remaining 3, so again, out of the 10 true, 7 were equi. Out of the remaining 3, 2 patients were diagnosed as having Rhodococcus globuralis and Rhodococcus erythropolis. So I'm sorry if I'm mispronouncing these. Microbiologists don't swarm on me with trolling, but I'm trying my best. Well, they were noted to have isolated bacteremia suspected to be secondary to a central line. And interestingly, 1 case was isolated from a CNS infection, and apparently in an otherwise known to be immunocompetent host, but only identification was done up until the genus level with Rhodococcus species. So out of these 10 or deemed to be clinically significant cases, the median age group was about 62 years of age. All were treated with 2 to 3 drug regimen therapy with a combination based on susceptibility, with vancomycin being the main backbone, along with either a macrolide or a fluoroquinolone. Interestingly, the duration of therapy was fairly long, close to 4 weeks or around 29 days, because my sense is that these were deeper pulmonary infections like empyema or cavitary pneumonias, which usually need longer than your usual pneumonia treatment. And thankfully, all of them were cured or thought to be cured at 90 days with having no mortality from it. But again, the limitation is that this is only 10 cases.
Mhm.
And interestingly, the non-equi, I think I mentioned this in my first answer, were more associated with having some sort of a invasive device in the patient, like a central line or a VP shunt or a dialysis line. So why does the equi cause more pulmonary process, whereas the non-equi cause more line or device related? I don't know. Could this be because of local contamination or inoculation being more associated with non-equi species, or is it something else that we don't know about? These are just hypotheses for now, but interestingly, non-equi are more associated with invasive lines, whereas equi are more associated with clear pulmonary processes.
Hmm. Very interesting. Thank you. So Nancy, backtracking a little bit, focusing on the AST aspect of this and kind of helping to guide therapy. You guys performed AST on about 200 out of the roughly 300 or so isolates that you recovered. Can you talk a little bit about your general observations with respect to susceptibility patterns that you observed for these isolates?
Sure, Ellie, happy to. So, for the genus Rhodococcus in general, we noted a high level of resistance to amoxicillin clavulanate. So, about 40% of the isolates were resistant. The extended resistance to the extended spectrum cephalosporins. So, about 50% of the isolates, for example, were resistant to ceftriaxone. Amikacin resistance, tobramycin resistance at about 17%. But thankfully, nearly all the isolates were susceptible to imipenem, linezolid, vancomycin, and rifampin, and many of them had high levels of susceptibility to trimethoprim, sulfamethoxazole, clarithromycin, moxifloxacin, and minocycline. And I should add that there's a little bit of an anomaly with the CLSI recommendations for testing of Rhodococcus equi compared to the other aerobic actinomycetes. So there's a standard panel that we use for Nocardia and Gordonia and Sucamarella. We use that same panel for the Rhodococcus species, but in addition, CLSI recommends that you test 2 additional drugs, vancomycin and rifampin, only for Rhodococcus equi, and so that's why the number of isolates tested in our paper for those two drugs are lower, because we only did that for Rhodococcus equi. And the interpretive criteria for Rhodococcus equi for those two agents with the breakpoints are found in the CLSI M100 document, and it's the breakpoints for Staph aureus. So in the bacterial AST document rather than the mycobacterial document. So a little bit of an anomaly there, but that's the recommendation for equi. So
Very
Thank
clear.
yeah, I know.
Adi, there was an interesting distinction or discordance rather in susceptibility to fluoroquinolones in the study. And you mentioned that those are frequently part of multi-drug therapy for the significant infections. What was that discordance and what are your thoughts about what it might have been due to?
The discordance is that some of the isolates were resistant to fluoroquinolones, with the mechanism of action, at least our hypothesis being a mutation in the DNA gyrase subunit. But that's just a hypothesis, and maybe Dr. Vanjana can comment more on that. But in summary, from a treatment standpoint, we saw, as Dr. Vanjanak mentioned, that for equi species, we saw good amount of susceptibility to vancomycin and imipenem from an IV agent standpoint, whereas an oral agent standpoint, linezolid and rifampin having intracellular killing or having high levels of susceptibility, at least in the equi species. For the non-equi species, we found more susceptibility to amoxicillin clavulanic acid and cephalosporins, amikacin, tobramycin, cipro, moxie, in general more susceptible than equi species. But for equi species, there was resistance encountered to your classic penicillin or beta-lactamase combination, cephalosporins, including cefepime. So it's an important distinction to make when you're choosing empiric regimen, that if you have equi species, then your empiric agent from an IV standpoint should be vancomycin and imipenem. Whereas for non-equi species, you could probably get away with amoxicillin, clavulanic acid, and cephalosporins.
Nancy, so Addie kind of brought this up earlier, and just now, kind of that limited data for non-equi species. So you guys decided to separate out and look at AST for equi versus non-equi species. Can you tell us about that and whether you identified any AST differences between those two groups?
Yes, happy to, Ellie. So when we divided our susceptibility testing results by species, we had data from 105 isolates of Rhodococcus equi and 94 non-equi species, 94 non-equi isolates. And so, as Dr. Shah mentioned, we noted high levels of resistance to amoxicillin clavulanate and the cephalosporins, and that tended to align more with the Rhodococcus equi rather than the non-equi species. And as he mentioned, the non-equi species had increased rates of susceptibility to amikacin, tobramycin, ciprofloxacin, and moxifloxacin. And the good news is that both equi and non-equi species had high rates of susceptibility to linezolid, rifampin, and vancomycin, with greater than 80% susceptible in both groups to trimethoprim sulfamethoxazole and clarithromycin. So I should caution that the susceptibility testing results are in vitro MIC values, and the clinical correlation with the in vivo activity for Rhodococcus species is not really well known or well studied. So the breakpoints that we use are really set for nocardia species, and not Rhodococcus species. So there's more study that needs to be done to make sure those interpretive criteria are completely appropriate for Rhodococcus species. But in general, the non-equi species, as Dr. Shaw said, demonstrate less resistance in vitro to antibacterial agents than does our equi. And could this be due to selection pressure generated by the increased use of antibacterial agents on horse farms to prevent Rhodococcus equi infection in foals? I don't know. It's being interesting to look at it. Could it spill over to human Rhodococcus equi infections? I don't think we know the answer for certain yet, but I know some of our veterinary microbiology colleagues are looking at this question pretty heavily at this point in time. So it'll be interesting to see what they find as their work progresses.
Thank you, Nancy. Very interesting to have that veterinary connection. Adi, let's look at the big picture. What would you say are the key take-home points from this study from a treatment and clinical perspective?
Sure. So the key take-home points would be to identify the differences in the equi and non-equi species. identify the kind of clinical patient or the clinical host that you may see these infections. So just to summarize, more the immunocompromised, HIV, solid organ transplant, bone marrow transplant, identify the sources of infection that these usually come from. For equi, seems to be more associated with pulmonary processes leading to bacteremia. For non-equi species, seems to be more associated with invasive lines, catheters, devices, VP shunts, dialysis lines, and so on. Identify and appreciate the difference in the susceptibility patterns of equi and non-equi species. And I think I should be clarifying and stressing that, yes, while the non-equi species seem to have more susceptibility to amoxicillin clavulanic acid and cephalosporins, I would still recommend going empirically with vancomycin, imipenem, linezolid till you know susceptibility patterns from your microbiology colleagues. And most importantly, have a very close association with your microbiology lab so that you can identify these newer species and identify what your clinical experience has been. Make sure of the morphological similarity with mycobacterial TB and nocardia so that you don't misdiagnose them. And lastly, case reports are looked down upon, unfortunately, in academia. But I think that if you see a rare case, write it up because that's how we accumulate evidence over time so that in 5, 6 years, we can have a larger database of patients that we can add and do a more descriptive review of these type of emerging pathogens. So those would be my take-home points and a little bit of advice to trainees, and I myself take that advice. If you see something new, work with your microbiology colleagues and write it up because sometimes someplace somebody is going to PubMed it and your paper is going to guide therapy for their patient.
Yeah.
We did not plan this, but I'm going to do a plug. ASM is coming out with a new journal, ASM Case Reports, and it will feature those important cases as you described, Adi. So more to come on that. It's not ready yet, but it's coming soon.
Okay. Well, be ready for many submissions from us then.
Yes.
Well, Adi, I think you summarized everything really well. I think your plug about publishing, these rare cases, which as they accumulate, we continue to learn from, is really a great way to round out this this discussion. So thank you for that, and thank you for joining us today. Nancy, thank you for coming on. It's good to see you. You're only
Thank you.
5 miles away, but I don't see you as often as I'd like. So thanks for coming on. And Alex, good to see you as always.
Great to see you.
Any hints for next month's topic?
No, I haven't chosen a paper yet, but I've seen a number of interesting ones go by on the journal's website. So I'll pick a good one and we'll have a good time.
Can't wait. Thank you guys again.
Thank
and
you.
Thanks everyone for
Thank
tuning
you.
in.
Have a good weekend.
You too.
Bye-bye.